Thank you so much, Dr. Pai. That was some great information. So we've got about 27 or so minutes for Q&A. And if anybody is interested in asking a question, you can raise your hand in Zoom. We will put the instructions for how to do so in the chat. So we can go ahead and start getting into some questions. So should a person who's asymptomatic and in generally good health get tests? And if so, what tests should those people get?
So it all depends on what their symptoms are, right? And so one thing when I see patients is that we actually do a couple of things. We have them watch a 3-hour video, which I've created just to kind of cover the general of inflammation. We recommend them to read the book as well, because the more information that a patient has coming in to see me, the more optimized their time is, because I can go directly. There's an online questionnaire that we go through, like integrative and functional, and it's not just the conventional, here's your medical form. And by doing so, it really allows me to guide the patient to say, like, what do you really need? Because, all these tests sound impressive and, everybody can have it, but not everybody needs it. Right. So it's if someone's coming in healthy, they might think they're healthy, but actually when we take a more detailed history, most people will have a problem. It could be just like slight fatigue. It could be like, oh, I have insomnia. It could be like I have anxiety. So just, there's not necessarily diseases per se, but they're imbalances, dysfunctions, or other type of conditions. So that's what I need to have. Like once I take the intake, then I can help guide the patient to, like, hey, let's look at your nutrition, or hey, let's look at food sensitivities, or hey, let's look at the microbiome. Some people, we can do all of it, by the way, even if they're super healthy. They just want to know where they're at. Some people's biomechanics, or what I'd call is their dosha, their mind body constitution, and from an Ayurvedic perspective, I'll give you an example. Someone who's the fire constitution, very pitta, very fire oriented, they have a very strong digestion. So they don't really complain of digestive symptom problems. But sometimes just based on their history and their environment, their job, what they eat, and all that stuff, it's like, we got to check their microbiome. They have no complaints. They're having normal bowel movements, no heartburn, no reflux, no bloating, nothing like the other type of body types that would have. And we find that they can have just as much dysfunction. So the challenge is sometimes, even when we take a history, we have to start looking at other aspects of evaluation. And that's when we look at indigenous medicines like Ayurvedic medicine and Chinese medicine. There's other aspects from the body type, or taking a history or physical, or even physical exam, or even looking or hearing or asking certain questions that they fill out before they see us. It already guides me, like, this is an area that we would have to look at, even though the conventional aspects of the questions may not, bring us to that conclusion. And that's why we're having this total integrative approach is really helpful.
And what are tests that everyone should get regardless of their health status?
Well, I think I mentioned that in the beginning, like, getting the vitamin D, getting the lipids, A1C from a conventional standpoint, CBC, CMP. So that's all in the beginning of it. But if they need to have these other tests, then that's what they would need to get, right? But again, just say everybody needs tests, that's also not feasible. What's feasible is the following, and I want to make sure I express this very clearly. How I practice is very different than most of these other doctors, meaning, especially since there's an online explosion of health coaches and functional practitioners, which is like the buzzword of the day. I did functional medicine now 24 years ago, right? Certified. And now, like, everybody's like a functional medicine practitioner. But a lot of these practitioners, unfortunately, I'll let you know, is that their whole practice income is based on upcharging laboratory tests. We're one of the first and only practices still now, 24 years going, that we don't upcharge testing. So what that means is that I don't get a test and then charge it. A lot of these tests are very expensive. Like, now, cash base, it might be like $300 on a test. Still expensive, but $300. But an insurance, if the insurance covered, it might be a $2,500 test. But a lot of these functional practitioners, and I'm gonna get a lot of backlash from opening up my mouth and saying this, because it's their livelihood, but it's like they're upcharging. So I got patients who come to see me and they spend $3,000, $5,000, right? They put on their credit card, blah blah blah. Oh, my naturopath, my chiropractor, the health coach said I needed this test. I'm like, okay, well, you could have got that at a fifth of the price, right? Just pay the lab directly. Here's the price. I don't upcharge. We don't upcharge labs, conventional or functional tests, because I want patients to save as much money so that they can buy better food, do organic, maybe learn some meditation. Like, when we see our patients physically, we have cooking classes, we go shopping with them. It's really teaching them, even if it's by Zoom, it's like teaching them how to go shop. And we can tell you, like, well, these are the brands of foods, if you're buying a packaged food, how to read the label. These are the ones that have less salt, less sugar, still more protein, more fiber. So we really want to help with that. But there's not just like everybody needs every test, but that's why we do individual consultations. If someone just sells every single test also, then I'll be questioning their evaluation. That means they're just selling products and selling programs. And that's also a little bit of a misguidance.
And you talked a little bit about colonoscopies, and what are your thoughts on like colonoscopies as you age, or mammograms as just sort of like you're getting to this age, take these tests regardless of your health status?
So really, it's not given that way. It's actually given based on your history. So if you had a colonoscopy and there was no polyps or no pathology, then they kind of skip it. They start spacing it out, and eventually, like, you're done. Like, you don't need them anymore, right? Now, one interesting thing is that someone has colon polyps or any kind of pathology in their gut, inflammation, colitis, and all. If they go on a plant-based diet, and if we test them for their food inflammatory systems and we give them anti-inflammatories and strengthen their immune system, then on their next colonoscopy, it's clear. Then after that, the GI doctor's like, you're done. Like, you don't have to. It's the reason why there's so much intervention and screening, which is understandable and needed, by the way, is because the average person is not. The average person is a pro-inflammatory lifestyle, pro-inflammatory diet. And now we have pro-inflammatory environment. And so they're at risk. I mean, when we see this epidemic, and it is an epidemic, I mean, cancer is number 3 or number 2 risk now out of heart disease. Yeah, number 2. Then we have to understand, like, that's terrible. Like, we shouldn't be having, the second cause of death is cancer in the United States. Heart disease, number 1. And here's an interesting thing to talk about on heart disease, just real quick, since we're talking about cancer patients. In 2018, 2019, and 2020, the number 1 cause of death in cancer patients was, in the entire United States, heart disease, not cancer, right? Because still the number 1 cause of death is still the number 1 cause of death, regardless of whether they have number 2, number 3, number 4, number 10. So where sometimes the system fails is that we help the patient with cancer, but we're not still looking at the common thing that's getting everybody, which is heart disease. What we like to look at is everything. When someone comes with a cancer, someone has diabetes, someone has heart disease, like, we're still looking at everything because it's optimizing. It's reduction of risk of a variety of factors. That's the epigenetics, diet, lifestyle, environment, belief system is what we do with our patients. That's what gets them better. It's not just like only doing one. A lot of people like, I just do hardcore plant-based. Do you exercise? No. Are you doing any kind of stress reduction? No. Are you looking at environmental toxicities or cleaning up your environment? Or no. Then that's not going to take you all the way. Right. So it's a little bit of everything. But going back to the issue of those screening tests, we do need to have those screening tests, but those screening tests are lower if your lifestyle is better. And is there a risk? There is always a risk of doing some of these scans. So are they doing some of them too frequently? Sure. Is there alternative scans or other ways and methods of doing that? Yeah, we can do a blood test, cost a little bit more money, but that's another way to screen 50 different things rather than just 4 things, like with a colonoscopy, a mammogram, and PSA and a chest X-ray. Well, what about the other 46 type of cancers that people can get? So there's options available for those people who don't want to do those kind of screenings, but screening still should be done because you can still lead a perfect lifestyle and still get cancer. You can still lead a perfect lifestyle, and it's because there's environment, there's stressors, there's a lot of other aspects that can trigger cancer. So a lot of people think I'm free of it, but if it's the second cause of morbidity and mortality problems in America, then we got to be looking at it. It's just not just what I'm eating. Eating's a big factor, don't get me wrong, but a lot of people think I'm healthy enough or I'm eating clean, I don't have to worry about that. You should be worried about it, and we can help them with that.
So we had Dr. Pam Popper on a couple of speakers ago, and she's very skeptical of a whole bunch of different tests, specifically for healthy people. Obviously, if you're sick, if you have something acute, then it makes sense to go get screened, according to Dr. Popper. But if you're otherwise healthy, the risks of getting brought into the medical field and having adverse effects, such as side effects, or in the case of a colonoscopy, getting a perforated colon, a bunch of different issues with mammograms. She was saying she was stating a statistic that for every 1 person that benefits from the mammogram, there are 10 people that are injured as a result of the medical, of being brought into the medical field and having different procedures done based on something that did not turn out to be breast cancer.
Sure. And there's issues like, so like, for example, like if I see a patient that has breast cancer, right? So then there's programs, right, that like National Health, NHS, in England, right, like Breast Predict and stuff like that, where you put in the parameters of what they find, right? And then you can actually assess in that patient based on real-time data, like if I were to do chemo, or if I do radiation, or if I do surgery, if I do this, like, do I really need it or not? Not just applying like everybody just like, you need this or that, right? Now, is there over and saying like you said like you get something and now you're in this train, right? And you can't get off. And they're doing invasive procedures at the end of the day don't pan out and might be actually causing more harm. Then good. Yes, there's absolutely data to support some of that. But you can't say that you're not screening though, because it's still 50%, like the number two cause of death, right? So good that you have to be cautious that some of these things have risk and some of these things can cause false positives, right? So they're over invasive treatments. But then what are you going to do, right? So then it's like, well, then we have blood tests. Blood tests is simple, right? So like there's opportunity and answers for those people like I don't believe in mammograms, I don't believe in colonoscopies or like this. But then putting your head in the sand if it's number two, because you're probably going to die from number one, number two, or maybe number three, right? Because that's the cost, right? So no one's free with it. It's not a perfect system, but the reason why there's so much screening is because there's so much cancer. But the problem with some of the screening is that they're not catching it early enough. So if we can get something that's on the early side of like circulating tumor cells. Now we're not talking about circulating tumor cells when you go to oncology too much, because right now there's a few companies that are doing it. Some of them are covered by insurance. Like if someone has cancer and they have really good insurance, some of them aren't. But like in 5 years, like right now, England, when they start putting this every year, starting next year, everybody in the country gets a screening, like it's going to be common because the whole country is going to be doing it. Then you're going to start seeing these numbers drop because the earlier intervention. It's not like once you see it, it's there. Well, that was a little too late, in my opinion. It's good that we have it because we want to see it, right? Because then those people still would have been missed. But it's bad that we had to wait to see it, right? And that's where like earlier intervention and changing your diet and lifestyle now. Like I have patients all the time, and here's the biggest challenge that you'll see with medicine is a lot of doctors say, "Well, you're 70." Or older. Well, it doesn't really matter because the cancer will be this. Like I'm always looking at optimizing a patient's health at any age, right? Like everybody deserves to have the best health possible. And most Americans, unfortunately, in the United States have never experienced optimum health. They felt better and they have average health, right? They're not up here. They're just not down here. They're kind of treading water, but they're not sailing, right? They're kind of swimming. And we want people to sail. And that's why I have patients sometimes they're 90 years old, they're coming in my office. It's like they want to still feel better. I'm like, yeah, we can still feel better. Aging is not a lot of people are kind of put out to pasture. There's a lot of ageism in Western medicine now. It's like, well, we expect you to have blood sugar problems and high cholesterol, memory problems. All it's like, no, that in these other countries and these other places, they don't have that morbidity and mortality problem. So we have to make sure that aging is not a disability, and we also have to make sure that we're not also intervening and causing too much medical problems, right? But we also can't say, well, we're not going to do anything, and just because I eat organic or just because I exercise or just because I do cardio, then I'm free of it. Then that's also like you have to understand like there is science to back up what we do, but we have to be careful that sometimes there's an invasion of misinterpretation or over analyzing sometimes.
So now one of the things that that Dr. Popper was talking about was this idea of early detection. And while it's very profitable to do early detection and you bring people in and give all these procedures, a lot of times the issues that are detected are things like cancers that they would have died with, not of, right? Or they're pre-cancers. They never would have actually become cancer. Or she was talking about with mammograms, there's an indicator of the potential for cancer, but now it's being treated as a disease in and of itself, even though it is not at all, it is not at all cancerous. What are your thoughts on the risk of the ever creeping early detection of disease, getting to the point where everyone seems like they have cancer now, and therefore they go and they treat it, and now everyone's a cancer survivor, but they never would have been affected by what the medical system is calling cancer, for example.
Well, that's partly true and partly incorrect. It's still the number two cause of death, right? So cancer is prevalent, right? Now, is early detection, can that be a problem? Absolutely, yes. Like we talked about it before. However, it's the expertise of the provider of like, if someone has elevated circulating tumor cells, doesn't mean that we have to go in and do an invasion. Doesn't mean I have to do a biopsy. Doesn't have to do it. It's like, can we lower those back to normal with natural therapies, increasing the immune system functioning, lowering inflammation, getting all the epigenetic changes better? Absolutely. When we have like the longest surviving cancer patients with very, very difficult cancers, it's not magic. It's not like, oh, I took this special IV. It's understanding the epigenetics and understanding science, right? So we don't want to throw out the baby with the bathwater, and we don't want to say like, oh well, just because there's potential over injustice. There is potential over issue. The challenge right now is that we have patients that are coming in who have now, which most patients who have cancer now are not early detective cancers. The majority of people who are coming in with cancers are stage 3 and stage 4 cancers that have not even been picked up. Why? Because they haven't had any general health care to begin with. So when we're talking about people who are like now looking at like early detection issues, right? Like then that's a little bit more of a proactive patient or a higher affluent, affordable patient that has excess expenditures that they can do so, right? Like, oh, I can get a scan, a full body CT scan, right? Hollywood people and all these tech people, like, let's get a full body scan and all stuff. That data hasn't shown anything right now. That's why all the medical recommendations, like, no, that actually can cause more problems because, again, some of those things will resolve, right? The average person has 6 to 8 cancers a year that the body actually just takes care of it before it becomes a problem. 100%, right? So, yeah, we don't want to overdo that. But if there's risk factors, and there's bad lifestyle. Unfortunately, there's a more bad lifestyle than anything else. Then we want to, and the problem is that most people just haven't had rich, just general screening. So there is people who are actually over screened, to let you know, right? And here's the problem is that when we have private insurance, this is another issue with all that, right? Which Pam is probably not talking about. But when you look at countries and systems that are universal payers, right? They're more of a universal care kind of concept. Then we're looking at this from a different perspective. But here, the privatization is a profitability. So yes, there is a little bit more over interpretation. There is a little bit more aggressiveness, right? Which is causing definitely potential harm and unnecessary procedures, right? And that's a profitability of a system because it's driven by profits, but not by public health reduction. And that's why when you look at countries who use screening appropriately, because they're looking at cost saving measures for the whole population, they don't have the problems that we do.
Right.
Even though they're using the same technology, right? It's because it's how we read something. Like, and when you see like these wonderful cardiologists behind me who will speak, and on these lectures and stuff, it's like they can tell you, like, you get 10 doctors in an office looking at an angiogram, depending on how conservative or liberal that person, depending on how many stents they put in, or how many ex-wives they have, or cars that they have to pay for, or children in Ivy League schools or not, then they might be more aggressive saying that that's a 70% blockage, because it's not a measurement, right? These are like subjective. So 10 doctors, you might get 10 different readings of like, yes, we don't need to stent this. And some of these people will say, yes, we might need to stent this, right? So there's a little bit of like, depending on the profitability or that financial drive. And now you can see in hospital systems, unfortunately, with healthcare, is that doctors own groups or the insurance owns group, or now there's fraud now, right? There's a lot of fraud, billing fraud that's happening. So we have to be really careful on all this. But when we look at this kind of universal healthcare, it's not the perfect answer, right? You can still get private care, even when you haven't, you can go see faster. But most people are not getting just general screening because they can't afford care at all. They can't even afford health insurance, for example. So then when they come in, it is a stage 3, it is a stage 4, right? And that's the problem. Then that the cost of care is astronomical. And if you go back to my original and inflammation lecture, I actually have a section in that lecture where I start talking about the cost of care as it goes on. And the problem is that when we catch it at this late stage, then we're talking about hundreds and hundreds of thousands of dollars. And the number one cause of foreclosure is now healthcare, right, on a home. So it's like, one health incident, that's how expensive it costs. So we have to really look at the, balancing, this over intervention, but also not saying, well, hey, some of this might be potential. You have to look at each individual that way and deal with that.
And did you say something about celiac? Thank you for that answer. Did you say something about celiac disease being able to be reversed?
Yeah, because celiac disease. So the misnomer of all autoimmune diseases, by the way, right? And I write this in my book, and I've been talking about this for 25 years now, is that autoimmune is a misnomer conventionally. Now, it is true that the body's attacking itself. So there's autoantibodies in whatever part of the body that is attacking itself, right? So with celiac disease, it's in the GI tract, right? But we have rheumatoid in the joints, for example. MS is the central nervous system. And lupus is kind of more in the kidneys, right? So yes, we can measure these tests and say, hey, there's inflammation, there's attacking there. But when you look at cell biology and anatomy and immunology, like from a real standpoint, like when you learn it in medical school, the cell was never designed to attack itself. Your military of your body, which is your immune system, your Army, Navy, Air Force, Marines, and Border Patrol, it was more about protection and defense. It's about protecting against foreign invaders, bacteria, viruses, parasites, cancers, chemicals, trauma, damage, and repairing it. So we had our Army, Navy, Air Force, Marines. We had also our Border Patrol, and we have our Army Corps of Engineers fixing bridges and dams when they collapse, right? So there was this thing that the body was always defending, fixing, repairing, but now it was never told to attack itself. When it attacks itself, there's always a trigger. The challenges with Western medicine is that we have things called steroids and infusion drugs. So if someone's flaring with rheumatoid arthritis, for example, they come in, or lupus, they take these drugs and magically they'll feel symptomatically better. I don't mind that, because they're drowning, throw them the life vest. But we have to teach them to swim, and we have to get them out of dangerous waters. And that's what we're really good at doing. So when we look at celiac disease, going back to your question, so celiac disease, again, we used to say, well, it's due to having a gluten exposure. So you got to go gluten-free, right? And that's true. That's the trigger. And that triggers this autoimmune response into the GI tract. But what we didn't have back then, 30 years ago, 20 years ago, even 10 years ago, was the ability to understand, well, what can we do to help their immune system by strengthening it, not suppressing it, what to find the triggers of inflammation that are coming in outside of gluten, and how do we restore and fix that microbiome? And when you do that, the antibodies will go back to negative, and the pathology with the biopsy, which is gold standard, goes to negative. We didn't have that. So we would just tell the patients, traditionally GI doctors, don't ever eat this food. And luckily now you can go for gluten-free everywhere now. Like that was, 20 years ago, 30 years ago, it was really hard to be a celiac patient. But it's not only just celiac disease that's a problem. Celiac is, more common now, but gluten problem is even bigger, right? Because gluten in our perspective is the precursor to the celiac. It's just like a little bit of the bridge or the dam is kind of broken. It's not completely washed away. Right. But the gluten, if that's not fixed and addressed early enough, then that can progress where the gluten IgA in the testing can trip gliadin and tissue transaminase and reticulin antibodies. And the body, it's like, if there's too much inflammation and too many triggers, the immune system says, I'm out. It's kind of like, we're not getting paid enough. We're working too hard. Unions on strike, and we go. And that's where in the system, the immune system is like, it can't do that. We find those triggers and we resolve it. So rheumatoid arthritis can be halted. Lupus can be reversed. MS can be slowed down where the person can regain function. The problem is that we're just always easily treating the symptoms because there's a drug that will eventually calm things down, but it's not with unwanted side effects, right? We always have to look at what's the underlying imbalance or dysfunction or disease, and resolve that rather than just treat symptoms. Even with natural therapies, a lot of natural doctors just give natural therapies, not getting at the underlying factors. And so going back to celiac disease, yes. So when we have patients, what we've seen earliest has been 11 months, but on average is 16 months, right? Because they got to go gluten-free. We've got to calm the gut down. We've got to find the foods. They usually have some kind of increased intestinal permeability. They might have nutritional deficiency. They have stress. They have all these other things, other imbalances. Because remember, it's not just the celiac disease. They have other problems, right? So we have to fix all these systems. But once you fix all these systems, the GI pathology can restore its function because the GI is repairing itself every 3 to 5 days. Those cells are replenished. So the GI problems, like people have irritable bowel, Crohn's disease, ulcerative colitis, those are the fastest and quickest inflammatory conditions to treat. Mm-hmm. Right? It's just that when it gets deeper into pathology, like someone has rheumatoid arthritis, we can slow the progression and stop the triggers, but the damage has been done. Like that joint has been dysfunctional for 15 years. It's dysfunctional. I can't fix that, but I can prevent the progression from getting worse. Right. So the key is if we can get these things early enough, then we can prevent the onset of that chronicity of disease and inflammation.
Great, thanks. So I'm going to open up to the audience. We just have about 3 minutes left. So I guess the answer will have to be a little truncated. The question's going out to Ali D. Please state where you're from and state your question.
I live in Southern California. I'm in the garden daily, skin exposed, no sunscreen, natural soap. I take 50,000 international units vitamin D twice a week, which is 100,000 units. I take 5,000 over the counter daily. So that's 135,000 a week I'm taking. And still my level is 13. Why am I not absorbing it? And what else am I not absorbing? And I'm concerned for my health for cancer, COVID, bone, teeth, etc. Thank you.
So yes, thank you for the question. I think you asked the question previously in the panel discussion, but I'll answer it again. So there's some kind of malabsorption. So you are taking a high dose, and that's correct. There's 2 different ways of looking at it. You can take a weekly high dose for several weeks, but then taking the daily is actually better. But if you're taking both and your levels are deficient, under 20 is deficient, not insufficient, but deficient, then there's a malabsorption issue. Even if you're taking it with fat, remember, so you say, I'm taking it with fat, a little bit of avocado, a little bit of, nut butter, something like that. If you're not enhancing absorption, then there's a microbiome issue, right? So that's why I would recommend is like if we were to see you as a patient or do a consultation, then we would evaluate what else is coming in. Is your microbiome? Are you not able to break it down? Is it the enzyme problem, or is there inflammation in the stomach? Is there a little bit of gastritis? There has to be a reason, because not that you're doing anything wrong, it's just that we need to make those things work better for you. Because you're right, we want to get your levels up at least a little bit higher so that you have better bone density, you have better risk of overcoming a COVID or lowering your risk of allergies or inflammatory issues, or all the other 3,500 studies that will show that having better vitamin D have better outcome. So, but it's not necessarily the product problem or the drug problem now. It's actually going to be something with the digestive system. And so I would recommend doing this, like the GI testing, and also looking at other inflammatory triggers in the diet, and also even looking at some of the nutrition elements to see if there's something else that's going on that's affecting that. Because remember, if you're having a problem with that, like you mentioned, which is a really good observation, there might be other malabsorptions. So yes, you're measuring vitamin D. Yes. But there might be other, like all the nutrients be down. So there might be a whole malabsorption problem that we would have to look at.
Great. Thank you. So we've got about 1 minute left. Would you like to leave the audience with any parting words?
Yeah. So again, my name is Dr. Sunil Pai. I'm available for telehealth consultations. We're able to see people anywhere, anytime via now telehealth. So I'll be glad to help you, be a guidance, be a consultant to help you look at your supplements, look at your nutrition, look at your microbiome, being a second eyes and ears to your guidance to optimum health. And feel free to reach out to us. Please go to our website, sangemini.net, sign up, because you will definitely like to, if you can't see me as a patient, you will love to watch and follow our podcast, Take Back Your Health, which will be launching soon. And you definitely, if you're ever interested in looking at even products on our website that you can buy, you don't have to be a patient, but everything we have is GMP certified. We're looking at patented ingredients, clinical studies. So if you feel like, hey, I want to take something, I don't want to be a patient, but I want to take something that has been vetted, we've vetted everything in our store, and we actually are always looking at enhancing and improving those things. So instead of just buying something on Amazon and being buyer beware of those kind of things, we can provide you safe and effective products.
Great. So thank you so much for your presentation and all the information that you shared with us today. If we can unmute the audience so they can share their appreciation for Dr. Pai.
Thank you.
Thank you.
Thank you, Dr. Pai.
Awesome.